Welcome, future nurses. Think of me as your clinical professor today. We're diving into a high-yield explainer covering everything you need to know about labor and delivery. We're going to take all that dense textbook material about birth, postpartum care, and newborn transitions and turn it into actionable, life-saving clinical judgment for the boards and the bedside. Let's get right to it.
Okay, so here's our blueprint for today. First, labor foundations. Second, fetal assessment and resuscitation. Third, fourth stage maternal care. Fourth, essential nursing mnemonics. And finally, we'll wrap up with some NCLEX practice questions.
Let's kick things off with Section 1, Labor Foundations, the 5 Ps and stages of labor.
You should absolutely expect a select all that apply question on these 5 Ps. Any disruption at all in the passenger, the passage, powers, position, or psyche can seriously delay labor. And I really want you to notice psyche on that list. It's not just physical mechanics here, right? A birthing parent's fear or anxiety can literally stall labor. It's wild. So as nurses, providing that emotional support and advocating for their preferences, that's just as crucial as tracking their contractions.
Now you got to know these 4 stages cold. The first stage, that's all about cervical dilation, taking us right up to 10 centimeters. Then we hit stage 2. That's the active pushing phase that ends with the birth of the baby. Now I want you to pay close attention to the third stage. This one is defined by placental separation. So what are you looking for at the bedside? You'll actually see the umbilical cord appear to lengthen, and there will be a sudden gush of dark blood as the placenta detaches from the uterine wall.
All right, moving right along to Section 2, Fetal Assessment and Resuscitation, Protecting the Passenger.
Imagine you're watching the monitor and you see signs of fetal distress, like those dreaded late decelerations. These steps right here are your immediate life-saving go-tos. First, turn the patient onto their left side. Why? Because that maximizes blood flow to the placenta. Then, you're going to increase their IV fluids, apply oxygen, and absolutely immediately turn off any Pitocin infusion to stop stimulating the uterus. Then, of course, get the provider in there. And listen, under no circumstances do you lay the patient flat or bump up the Pitocin when the fetus is struggling. These steps are non-negotiable.
Let's fast forward to Section 3, fourth stage maternal care, postpartum recovery and assessment.
This transition period is a highly critical 1 to 4 hour window where our focus drastically shifts to preventing major maternal complications. Look at this chart. During that very first hour of the fourth stage, you are checking vital signs, the fundus, and lochia every 15 minutes. Like clockwork. You want to see lochia rubra, so red in color, moderate in amount, and absolutely no large clots. If your patient is soaking completely through a pad every 15 minutes, that is a huge red flag, and you need to act fast.
The big takeaway here is uterine tone. If you palpate a soft, boggy, or displaced fundus, you've got a major problem on your hands. The uterus literally has to clamp down hard and fast to pinch off those blood vessels. If it's loose and boggy, they are bleeding. Oh, and here's a pro tip. If you feel the fundus deviated over to the right side, it almost certainly means they have a full bladder. A distended bladder literally pushes the uterus out of the way and stops it from contracting, so get them to empty that bladder right away.
Next up is Section 4, Essential Nursing Mnemonics, Anchors for Exam Day.
When you're in a high-stress environment, mnemonics are lifesavers. Our first one is the APGAR score. This is how we evaluate a newborn's transition to life outside the womb. And guys, timing is everything with this one. You assess it at exactly 1 minute, and then again at 5 minutes after birth. You've got to memorize this breakdown. It tells you instantly if the baby needs help or if they are transitioning like a champ. Activity, are their muscles nicely flexed or just flaccid? Pulse, is the heart rate over 100? Grimace, are they crying vigorously? Appearance, are they nice and pink, or do you see central cyanosis? And just a quick side note here, a little blue in the hands and feet, which we call acrocyanosis, is totally normal for a newborn, but central cyanosis around the core or mouth, not normal. Finally, respiration. How's that breathing effort? Moving on to our next essential tool, the 4 Ts. Postpartum hemorrhage is incredibly dangerous. It's actually one of the top causes of maternal mortality. So you need to know exactly what triggers it, and that's where the 4 Ts come in. Out of these 4, I really want you to anchor the word tone into your brain. Uterine atony, or a lack of uterine tone, is the #1 cause of postpartum hemorrhage. If that uterus is boggy, it has lost its tone. The other 3 Ts are trauma, like perineal lacerations, tissue, meaning retained placental fragments, and thrombin, which points to coagulation disorders. So think about it. If you feel a firm fundus, but your patient is still bleeding heavily, tone isn't the problem anymore. You need to immediately start investigating trauma or retained tissue.
All right, let's wrap up our mnemonics with two crucial acronyms you're guaranteed to see in your high-risk maternity modules.
TORCH covers the major infections that can cross the placenta, but I really want us to focus on HELP right now. HELP syndrome is a severe, life-threatening complication of preeclampsia. It spells out major organ damage. You've got hemolysis, meaning red blood cells are literally breaking down, then elevated liver enzymes showing liver damage, and low platelets. That drop in platelets puts the birthing parent at a massive, massive risk for bleeding.
Okay, we've arrived at Section 5, NCLEX practice questions, applying clinical judgment.
Let's put everything we've learned to the test. Look at this scenario. If you're assessing a postpartum client and the uterus feels soft and boggy, what is your immediate, initial action? Think back to our chat about tone and hemorrhage. What is the very first thing your hands need to do?
The answer is massage the fundus. You have to physically stimulate those contractions. You never, ever just document a boggy uterus and walk away. And please, do not just push down on it to force clots out. If the uterus isn't contracted, pushing on it can literally turn it inside out. No way we want that. So massage it until it's firm. And then, once it's firm, your immediate follow-up is checking to see if they need to empty their bladder. All right, moving on to a classic newborn scenario. What do you think is the absolute biggest physiological threat to an infant born to a parent with diabetes, specifically in those immediate hours right after birth?
It's hypoglycemia. Safety regarding low blood glucose is your absolute top priority here. Think about what's happening physiologically. While in the womb, the fetus is producing extra insulin to handle the birthing parent's high blood sugar. But the second you clamp that umbilical cord, the sugar supply stops completely. The problem? The infant still has all that excess insulin pumping through their system. This causes their blood glucose to just completely crash. This is why early feeding, skin-to-skin contact, and super close blood glucose monitoring are critical for these babies.
Let's do one more. This scenario involves dystocia, which is basically just the medical term for an abnormal, difficult, or slow-progressing labor. Let's see what anatomical issue causes this specific complication.
What we're looking at here is shoulder dystocia. It's a classic conflict between the passenger and the passage. The baby's shoulder literally gets stuck behind the maternal pubic bone during delivery. Guys, this is a severe obstetrical emergency. It puts the newborn's brachial plexus nerve network at massive risk of being stretched or even torn. It requires immediate, coordinated nursing interventions to get that shoulder free without causing permanent damage.
So let's tie this all together. When you feel a boggy uterus, you aren't going to hesitate. You are going to massage it. When you see late decelerations on that monitor, you'll immediately reposition your patient. You have the knowledge. Now it's all about trusting your clinical judgment. I want to leave you with a question to think about. When that call light goes off on your very first labor and delivery shift, are you ready to step into that room and literally save 2 lives at once? Best of luck with your studies, future nurses, and I will catch you in the next explainer.